This is the third program of a 3-program series on acid-base balance. Program 1 describes the pH scale, cellular shifts of positive ions, and buffer systems, particularly the bicarbonate buffer system, and the role of the respiratory and renal systems in normal pH balance. Program 2 describes respiratory alkalosis and acidosis, and how the body compensates for such conditions. If you are unfamiliar with these concepts, please review programs 1 and 2 before continuing. This program will discuss 2 other important imbalances, metabolic alkalosis and acidosis. These patients are at risk for metabolic acid-base imbalance. Any pH imbalance not caused by the respiratory system is termed metabolic. The nurse must learn to recognize causes of metabolic acid-base imbalance in order to predict patients at risk for developing such imbalances. Must recognize signs and symptoms these patients might display and make assessments that reveal more about their conditions. Must diagnose causes and contributing factors, and whenever possible, must intervene to reduce or eliminate such causative factors. These nursing responsibilities are the same for all patients with pH imbalances. Alkalosis is caused by either a gain in base or a loss of acid, since either situation will result in more hydroxyl than hydrogen ion. So any non-respiratory cause of base gain or acid loss is a cause of metabolic alkalosis. Patients at risk of metabolic alkalosis may be divided into 4 major categories. The first group includes those with gastrointestinal losses, such as vomiting or suctioning, which removes hydrochloric acid from the stomach. The resulting alkalosis is due to the loss of chloride as well as hydrogen. When the negatively charged chloride ion is lost, the kidneys must retain another negative ion, such as bicarbonate, to maintain electroneutrality. So lack of chloride forces a relative increase in bicarbonate. This process demonstrates the relationship between gastrointestinal losses and renal response. Recall that the kidneys directly regulate the renal component of the bicarbonate buffer system, and that they have direct control over hydrogen ion or acid and bicarbonate ion or base. The kidneys, therefore, may cause metabolic alkalosis either by retaining bicarbonate, as happens with chloride loss, or by losing hydrogen. Most often, hydrogen loss is related to a series of events that begins with a drop in blood pressure to the patient's kidneys. This blood pressure change may be due to fluid volume deficit or insufficient plasma protein, which allows edema or loss of vascular volume to interstitial spaces. The decrease in blood pressure in the glomerulus indirectly causes the release of renin. Renin eventually causes angiotensin formation, which in turn stimulates the adrenal cortex to release aldosterone. Aldosterone stimulates the distal tubules of the nephron to reabsorb sodium, a positive ion, and to secrete potassium. If the condition persists until potassium is depleted, the nephron will continue to reabsorb sodium, but will now sacrifice hydrogen ion, leading to metabolic alkalosis. In a related way, potassium-depleting diuretics may also cause metabolic alkalosis, since first potassium, then hydrogen ion are depleted. A third major cause of metabolic alkalosis in patients is cellular shifts of positive ions, If serum potassium is depleted for any reason, intracellular potassium moves out of the cell to increase the potassium outside, and hydrogen ion moves into the cell to maintain the electrical gradient across the membrane. So potassium depletion leads to metabolic alkalosis in yet another way. The last major cause of metabolic alkalosis in patients is excessive intake of base into the body. For example, use of baking soda to self-medicate for heartburn. These then are the causes of acid loss or base gain in the body, and patients with alteration in these areas can be considered at risk of developing metabolic alkalosis. This patient has been on continuous nasogastric suctioning, which removes stomach secretions from the body. In addition, she's been taking ice chips frequently for a dry mouth, and the nasogastric tube is being irrigated with water instead of normal saline. Both of these practices stimulate excessive stomach secretions, which are then removed from the body, washing out not only chloride and hydrogen, but other electrolytes as well. Thus, she's at particular risk for metabolic alkalosis and must be assessed frequently for its signs and symptoms. Perhaps the most obvious signs are those related to the central and peripheral nervous systems. Alkalosis causes blood vessels in the brain to constrict, resulting in dizziness, faintness, lightheadedness, or perhaps blurred vision. Nerve membranes become more irritable because alkalosis decreases ionized calcium.
Are they tingling? And my lips are...
Symptoms related to this decreased calcium include tingling of the extremities and lips and carpal pedal spasm. If the condition is uncorrected, the cramping could proceed to convulsions. Nausea is always a possibility because prolonged or severe alkalosis irritates the brain's emetic center. Respiratory rate will be slower than normal. Note that this symptom differs from alkalosis of respiratory origin. In respiratory alkalosis, respirations are increased, causing the condition. In metabolic alkalosis, respirations are decreased, correcting the condition. In this case, the body needs acid to return to proper pH balance. A slower respiratory rate retains carbon dioxide and thus increases carbonic acid, helping correct the alkalosis. Once the nurse has identified the patient at risk for metabolic alkalosis and noted any signs or symptoms, further assessments should be made. Check reflexes, which are increased with alkalosis, and look for signs of muscular irritability, like tingling, carpal pedal spasm, or Chvostek's sign. Several laboratory values will help. Serum electrolytes will determine whether potassium or chloride loss is an underlying factor. Check the apical pulse for rate and rhythm. Arrhythmias can occur with abnormal serum potassium values, and ECG monitoring may be necessary. Of course, the most definitive measure of the patient's condition is an arterial blood gas, which is analyzed for pH, partial pressure of carbon dioxide, and bicarbonate. In the uncompensated condition, there will be 2 abnormal values and 1 normal one. In any alkalosis, by definition, the pH must be high before compensation occurs. The normal carbon dioxide tells us that the source of the imbalance is not respiratory, and therefore must be metabolic. The high bicarbonate is the source of the imbalance, due either to the gain of base or relative loss of acid. In partial compensation, all 3 values are abnormal. pH is still alkaline. Carbon dioxide rises due to compensatory hypoventilation. Bicarbonate is still high. Finally, with full compensation, only 2 abnormal values remain. pH returns to the high normal range, but carbon dioxide is still high to help achieve this compensation. The high bicarbonate indicates that the underlying condition that caused the original alkalosis still remains. It's merely being compensated for. Most of this compensation is respiratory, with decreased respiratory rate allowing retention of carbon dioxide and resulting in production of more carbonic acid. The carbonic acid in turn breaks down to form more hydrogen ion, which helps correct the alkalosis. Eventually, the excess bicarbonate will also be eliminated. From these assessments, the nurse can make the proper nursing diagnosis and, when possible, intervene to correct the underlying disorder. The central diagnosis for many of these patients is alteration in nutrition. This patient is receiving less than her body requirement related to gastric losses, as well as inability to tolerate oral intake. Nursing interventions would be instruction on food sources that are high in potassium or other means of nutritional replacement. Electrolyte replacement is another intervention that the nurse must understand and help administer. Both potassium and chloride ions are key to a patient's recovery from alkalosis. For compensation to be effective, the kidney must be able to eliminate excess bicarbonate ion. The presence of chloride permits the nephron to eliminate bicarbonate in the urine. Full compensation from alkalosis also requires the kidney to retain more hydrogen ion. If adequate potassium ion is present, the kidney will secrete potassium and retain hydrogen ion instead. Additionally, some of the added potassium diffuses into body cells, causing hydrogen to move out and help correct the alkalosis. Another relevant nursing diagnosis might be potential or actual fluid volume deficit. This deficit, too, may be related to excessive loss as well as inadequate intake. So oral and parenteral fluid replacement should contain sufficient fluid as well as specific electrolytes that may be deficient. Potential for injury is another possible nursing diagnosis. Feelings of weakness associated with decreased serum potassium or hypokalemia make this diagnosis likely.
I feel kind of dizzy. Do you really?
Provide assistance with ambulation until the hypokalemia and weakness are corrected. To review, metabolic alkalosis is caused by any non-respiratory gain of base or loss of acid. Causes of such changes include GI loss of stomach acid and chloride, renal gain of bicarbonate, or loss of hydrogen ion. Cellular shifts that exchange hydrogen for potassium or other positive ions, and intake of base from outside sources. Signs and symptoms of metabolic alkalosis include those related to decreased blood flow to the brain, such as fainting and dizziness, blurred vision, and eventually loss of consciousness. Signs and symptoms of neuromuscular irritability also occur: tingling or numbness of fingertips or lips, carpal pedal spasm, cramps, and even convulsions. GI upset is common, either as a cause of the condition or as a result of it. Hypoventilation helps retain acid to compensate for the condition. Assessment should include reflexes, ventilation, and hydration. Serum electrolyte values can be used to verify ion imbalances and to predict the likelihood of cardiac arrhythmias. The heart should be monitored by taking an apical pulse and, if necessary, monitoring the ECG. And an arterial blood gas is of great value in determining the degree of pH imbalance and level of compensation. Nursing diagnoses include alteration in nutrition, perhaps related to GI loss of hydrogen and chloride ions from the stomach, or related to knowledge deficit, especially of potassium sources. Another diagnosis is fluid volume deficit, which may be related to either excessive fluid loss or inadequate intake. Potential for injury is possible and is related to potassium loss and the weakness it causes. This completes the discussion of metabolic alkalosis. This patient with uncontrolled diabetes mellitus is also experiencing a metabolic acid-base imbalance. but this time it's acidosis. Acidosis is caused by either a gain in acid or a loss of base, since either situation will make the pH more acidic. Any non-respiratory cause of acid gain or base loss is a cause of metabolic acidosis. Patients at risk of metabolic acidosis may also be divided into 4 major categories. The first 3 categories are similar to those that caused alkalosis. However, the 4th category, acid production in the body, is different. As before, patients with GI losses are at risk of imbalance, but this time it's loss of bicarbonate from the intestine that causes acidosis. Patients with diarrhea, intestinal fistulas, or ureter enterostomies are all candidates for metabolic acidosis. Next are patients with renal changes. Acidosis will occur if either hydrogen ion increases or bicarbonate decreases. Bicarbonate is lost when chloride ion is increased, since more chloride is reabsorbed instead of bicarbonate. Hydrogen ion increases when potassium ion is increased. Excess serum potassium, or hyperkalemia, will cause the nephron to selectively secrete potassium instead of hydrogen, resulting in retention of hydrogen ion and acidosis. Since the kidney efficiently excretes potassium, the most common cause of hyperkalemia is kidney failure. At the cellular level too, hyperkalemia can cause acidosis due to shifts of positive ions across the cell membrane. As excess potassium diffuses into the cell, hydrogen ion diffuses out to maintain the electrical gradient. Acidosis results. Many patients with metabolic acidosis fall into a 4th category, overproduction of acid. There are 2 main reasons for this overproduction. 1. Any clinical situation which results in increased fat metabolism can result in acidosis. It may be malnutrition or starvation, as in anorexia nervosa, or malabsorption disorders, or, as in this case, it may be a result of uncontrolled diabetes mellitus. Insulin is required to move glucose into cells for use. Without insulin, the sugar remains unused in the bloodstream, and the cells must break down fat for energy. This process releases free fatty acids, which are then converted to ketones by the liver. Ketones are strong acids. The greater the insulin deficiency, the more fat must be metabolized, and the more severe the acidosis. A second source of excess acid production is lactic acid. This acid is produced anytime cells in the body do not have an adequate supply of oxygen, and anaerobic metabolism occurs.
Baby received a dose of bicarb. I think we need to give another dose, because I don't see baby's good urine output and everything seems okay. Still metabolic acidosis.
This baby was born with metabolic acidosis. Decreased placental blood flow during labor deprived the baby of oxygen for precious minutes, resulting in anaerobic metabolism and metabolic acidosis. In addition, this baby's immature lungs are less able to exchange oxygen for carbon dioxide, so a respiratory acidosis may be superimposed on the metabolic acidosis that already exists. In adults, oxygen deprivation and lactic acid production are usually associated with a severe drop in blood pressure, as occurs in hemorrhage or shock. These then are the main reasons that acid production in the body would increase.
Good morning, Mrs. Vanderhoosen. Good morning. Mrs. Vanderhoosen?
Once the nurse has identified a patient at risk of metabolic acidosis, she must watch for signs and symptoms of its development. As with all acidosis, CNS depression and increased cerebral blood flow are possible. Headache, confusion, drowsiness, feelings of fullness in the head, and mental stupor progressing to unconsciousness and coma are predictable results of untreated acidosis. As hydrogen ions increase, so do other positive ions, including calcium. The resulting hypercalcemia depresses nerve membranes and contributes to decreased deep tendon reflexes, lethargy, and mental stupor. A warm, flushed skin also results from decreased nervous control of peripheral blood vessels. Nausea is always a possibility with any prolonged acidosis or alkalosis due to irritation of the brain's emetic center. Respirations will be increased. Characteristic Kussmaul respirations will be evident as the lungs attempt to eliminate carbon dioxide and help correct the acidosis. Elimination of carbon dioxide permits an increased breakdown of carbonic acid and helps remove acid from the body. Note, however, that the formation of carbonic acid in turn is dependent upon the availability of bicarbonate. This explains the use of intravenous bicarbonate in treating metabolic acidosis. As with all acid-base imbalance, meticulous ongoing nursing assessments are necessary to detect significant changes in the patient's condition. Neuromuscular condition may be monitored by checking the patient's level of consciousness.
Mrs. Vanderdusen, Mrs. Vanderdusen, can you squeeze my hand?
If she doesn't respond to questioning, a pinch may arouse her. How's the skin color and temperature? In diabetic ketoacidosis, the skin is often flushed and warm. And the reflexes. These deep tendon reflexes are depressed, confirming the CNS depression. Serum electrolyte values may reveal increased calcium, chloride, and potassium ion concentrations. Life-threatening cardiac arrhythmias may develop since normal potassium levels are necessary for proper heart function. Check the apical pulse for rate and rhythm, and monitor the ECG if needed. Once again, an arterial blood gas measurement can reveal a lot about the patient's condition and level of compensation. In the uncompensated condition, pH will be low because the patient is in acidosis. Carbon dioxide will be within normal limits, indicating that it is not the source of the acidosis. And bicarbonate will be low, indicating the metabolic cause of the condition, whether due to direct loss of bicarbonate or relative gain of hydrogen. With partial compensation, all three values will be abnormal. pH is still low. Carbon dioxide decreases as the respiratory system begins compensation, and bicarbonate remains low. Later, with full compensation, pH has returned to the low normal range, but the other two values are still depressed. Carbon dioxide in compensation, and bicarbonate indicating that the source of the original acidosis still exists. From these assessments, the nurse can make the proper nursing diagnoses and intervene to correct the underlying disorder. Dietary counseling or other nutritional support may be needed, and in the case of the patient with diabetes, instruction in the administration of insulin and self-care as well to prevent the situation from recurring. To review, metabolic acidosis is caused by any non-respiratory gain of acid or loss of base. Causes of such changes include GI loss of intestinal bicarbonate, renal gain of hydrogen or loss of bicarbonate, cellular shifts that move hydrogen out when potassium or other positive ions move in, and production of metabolic acid, either due to increased ketone production from fats, as with malnutrition or diabetes, or lactic acid production with oxygen deprivation, as occurs in hemorrhage or shock, or in newborns after a prolonged labor. Signs and symptoms for all acidosis include those related to increased blood flow to the brain, feelings of fullness in the head, headache, confusion, drowsiness, and unconsciousness. Signs of neuromuscular depression are also common, including decreased responsiveness to questions and pain, depressed reflexes, and peripheral vasodilation. Nausea may occur, and with metabolic acidosis, deep sighing Kussmaul respirations to help with compensation. Assessments for acidosis begin with neuromuscular signs. Level of consciousness, reflexes, and skin color and temperature can all indicate neuromuscular depression. Serum electrolytes can be used to verify ion imbalances and to predict the likelihood of cardiac arrhythmias. The heart should be monitored by taking an apical pulse and, if necessary, monitoring the ECG. Hydration and ventilation should be checked, and an arterial blood gas will help determine the degree of pH imbalance and level of compensation. This concludes metabolic alkalosis and acidosis, the last of 3 programs in a series on acid-base balance.